critical limb ischemia.
Yeah, okay, yeah. Thank you very much for the invitation, also for Bart to ask me here to talk about drug-eluting balloons below the knee. What is their value in critical limb ischemia? So to start with what we usually think, what is the first goal actually if we treat patients with CLI, it's to achieve a straight line flow to the foot. And this is the most important thing. And in many trials we have seen this discrepancy between the patency actually and the limb salvage, and this we think is supporting our thought that actually only the flow, the initial flow is necessary, whether it restenotes later on or not is not so important for critical limb, for the limb salvage, because it's obviously better than the patency. So however, is this really the truth, especially in an area where we treat more by an endovascular approach, for example, long distal tibial occlusions by plain balloon angioplasty like this with very good results, but the restenosis rate is so high. Maybe it was more the fact in the area of bypass surgery, but now with doing more endo, it might be different. And we have seen that the restenosis rate below the knee is very high. We have here done a registry with long lesions, mean lesion length below the knee, quite nearly 20 centimeters, treated with non-coated balloons. You can see here the restenosis rate already after 3 months is tremendously high. So is this really of value in patients where we know that wounds take a long time to heal, very often more than 3 months? And is it not worthwhile to maybe look for something which will help us to have better patency and at least over that period of 3 months? And in fact, there are also other trials. This is all retrospective what we have so far, so we cannot really know whether it's important or not, the patency. But here, for example, in this registry or meta-analysis, 10-year experience here, again, the discrepancy between limb salvage and the primary patency of arteries in critical limb ischemia is seen here. However, they think that a lot of these patients need secondary interventions, and by this you can achieve this limb salvage rate, and the curve of the secondary patency is close to the limb salvage curve, and that this they count as an argument to look maybe for better patency. There's, as I said, only retrospective data. This here is, I think, important in this regard because it's prospective, not randomized, but a single, multi-center prospective trial in very few patients here with CLI and below-the-knee lesions, quite long lesions. And again, they found after 3 months a very high restenosis rate, as we have seen in our registry. I think you have to plug the technicians, please. Hello. You have to take the connector to the computer again. And here you can see that if patients had a restenosis after 3 months, there was no complete wound healing after 3 months. But if those patients had no restenosis after 3 months, there was a complete wound healing. So this demonstrates in a prospective way that patency obviously matters. At least it will fasten wound healing compared to those patients where we have restenosis. So we have seen this with drug-eluting stents below the knee and short lesions as this. We would implant a drug-eluting stent with very good results here. This was shown in several trials. Here, for example, long-term patency, or in the Yukon trials, sirolimus-eluting stent versus bare metal stent. Clinically, also after 3 months, 3 years, better with a drug-eluting stent compared to a bare metal stent for claudicants and for critical limb ischemia. However, of course, in long lesions, again, an example, 2 arteries occluded, treated with non-coated balloons after 2.5 months already re-occluded, drug-eluting stents will not work. So therefore, for these long lesions, we need drug-eluting balloons maybe to have better results. And as was mentioned already this morning, this is the first registry in the literature with long lesions below the knee in 104 patients treated with drug-eluting balloons. This is one example here with a quite long occlusion here from the mid portion of the posterior into the distal portion of the foot here was occluded, and we treated this here with drug-eluting balloons. You can see here the result is not really good. Actually, it's quite bad, and we have a lot of residual stenosis, maybe spasm, whatever. but we did already long inflation time, and we couldn't achieve a better result than this here, and we thought that would be a failure. But 3 months later, you can see here this result. Unfortunately, not really very good angio, but you can see here the artery is nicely open in all these dissections, and even the residual stenosis or collapse disappeared, and that was really quite impressive for us to see here. The results comparing to a registry where we use non-coated balloons, I've showed you after 3 months, 70% restenosis in long lesions. Now with drug-eluting balloons, we have found only 27% restenosis here after 3 months. A quite significant reduction in restenosis, retrospective, not randomized. And the TLR rate here also we have seen was quite impressively lower with a DEB than with a non-coated balloon. So clinically also quite good from Rutherford 5. Most of them were completely healed here after more than, well, let's say a year. So also clinically quite good results. However, at this stage, we already thought it will still be hard for the drug-eluting balloon to show that they are better than non-coated balloons. You know from the literature that also with non-coated balloons, as for example in these long lesions here by Ferraresi, 101 patients, you can achieve very good, excellent results with non-coated balloons here. 93% limb salvage rate after 3 years. Other examples also there in the literature, 111 patients with CLI, very low patency rate with non-coated balloons. Limb salvage rate, clearly something which can be improved with drug-eluting balloons. So there is place for improvement if you use non-coated balloons, but still, it's such a multifactorial genesis until healing in these kind of patients. It's not only important the patency, but many other things that it will be hard for the DEB to prove that we have benefit from this. The next step was a randomized trial from Liestro from Italy, single center randomized trial comparing the drug-eluting balloon versus a non-coated balloon. You have seen this. And he chose a 12 months follow-up, just very few data here. We can see here the lesion length was a little shorter than in ours, but still quite long lesions, and these were the results after 12 months. Restenosis rate after DEB, 27%, after non-coated balloons, 74%. So again, quite a significant difference. And he also has seen better wound healing, complete wound healing with drug-eluting balloons versus the non-coated balloon here in this randomized trial. So again, quite fortunate for the DEB. Here you can see the TLR rate also being better for the drug-eluting balloon versus the non-coated balloon. Then, as you have heard already, came the big multi-center randomized controlled trial. Of course, it's very important to have this initiated by Medtronic. And the endpoint was late lumen loss at 12 months. Quite ambitious, I think, and also clinically driven TLR and amputation rates at 6 months. Quite a lot of patients, however, randomized 2-to-1, which I think could be important for the results. And these results, as you have seen, were quite disappointing. There was no difference at 12 months. I think, as I said, it was quite ambitious to do it at 12 months. I thought, why not 6 months? Also clinically might be more important to know what is happening at 6 months than at 12 months, where most of the wounds are healed anyway, also with other treatment options. And there was a trend for more major amputations in the DEB arm, which was hard for us to understand. You can see here 8.8% amputation for DEB and only 3.6% for the non-coated balloon, and by this the balloon was taken from the market. Still quite a little shock for us. Not easy to understand why it should be actually worse for the drug-eluting balloon. Well, we have looked more to our data now, and we have analyzed more than, 200 patients where we have used the drug-eluting balloon now. I want to show you first one example. A patient with Rutherford 5, you can see here that everything is occluded. The anterior is occluded, the posterior is occluded, the peroneal is occluded, maybe here around 12, 13, 14 centimeters in length. So we thought easiest way would be to open this up. We have done this with drug-coated balloons here. You can see non-coated balloons here before we had the drug-eluting balloon available. You can see here the result. However, after 6 weeks, it was already re-occluded, and we had to come back for a second balloon angioplasty. Again, a non-coated balloon because we didn't have anything other available in this time. Re-occlusion occurred again after 4 months. And we had the third intervention now, implanting some stents that were just new on the market. We thought maybe we can achieve better results. This is here the result after stenting and PTA, non-coated stents, non-coated balloons. Third reocclusion happened 5 months later, and the patient had recurrent disease, and we had to treat once again with non-coated balloons because we didn't have anything else available. And this here is the fourth reocclusion, and then we had the drug-eluting balloons available and treated with drug-eluting balloons. And this here, on the left side, you can see once again the result after ballooning, and this is after 6 months. You can see it looks like as if it would have been treated the day before. So clearly, I think drug-eluting balloons work. They can indeed reduce the restenosis rate. And recently, we had the opportunity, treating the other leg, to do a 3.5-year follow-up angiography in this patient. You can see it's still open. And I think this is a nice example to demonstrate that these balloons really can make a difference. This is the whole career here for this patient. We could have helped him with reducing the TLR rate indeed. So as I said, we collected our data, 195 CLI patients now with critical limb ischemia, 205 limbs actually which we have treated with drug-eluting balloons. And you can see here most of them Rutherford 5, some Rutherford 6, similar distribution as in the big trial from Medtronic. And this is our amputation-free, freedom from amputation curve. 3.9% amputation is better than what has been achieved in the big randomized trial, and is similar to what have been achieved with a non-coated balloon in the randomized trial. As I said, it will be difficult for the DB to demonstrate whether it can reduce the already very low amputation rate treating below the knee by endovascular, but we can maybe avoid TLR rates and have a faster wound healing rate with drug-eluting balloons. However, now it will, of course, be difficult indeed in the future to demonstrate this. So to conclude, difference between CLI and claudication, I think, is clearly there. Restenosis is, can you once again take the cable and press it into the computer? Restenosis is not strongly linked to clinical benefit. Like in claudicants, there are many other factors influencing the clinical outcome, of course, and the results of the IMPACT DEEP trial was clearly quite a big surprise. Our practice, however, is still, if we have long lesions, especially small arteries, for example, we think there's a clear benefit for the DB. If we have restenosis, which we have to treat, we take the DB. Now the current drug-eluting balloon available is the one from Lutonix, the BART, the Lutonix balloon, which we use now below the knee. And we also use this, for example, if we expect a prolonged wound healing time, then I think also drug-eluting balloon, the Lutonix balloon, could be a good option nowadays still. Thank you very much.
Thank you, Andrei. We will allow now a couple of questions. So anybody, please come to the mic and please have, Andrei, maybe some have questions. Any question in the audience?
So I have a quick question, and it's related to the difference between your own experience in your center and what the trial showed. You know, because we continue to hear that in your center you guys got very good results with this, but it doesn't seem to be the case in the randomized clinical trial. So how can we extrapolate what you guys are doing at your institution to the rest of the world, basically? Because we are all anxious looking at this data, but we don't really quite understand what's happening.
Yeah, that's a difficult question, but it's not only our center to the rest of the world. There are other centers like the ISTRO, for example, who also have seen this quite tremendous reduction of restenosis. And I hear many doctors from Germany, for example, who are quite disappointing that the balloon is not available anymore. The one, now they use another one because they have seen good results. It is indeed very difficult to explain. So, as I said, first, I think choosing a 12 months late lumen loss endpoint is very ambitious. Maybe restenosis or reocclusion rate might have helped, although I think it was also not different. And in our experience, we have seen a difference at 3 months. But we have already also seen quite some restenosis later on, after 12 months with the drug-eluting balloon. And therefore, I would have chosen a 6 months, for example, endpoint that might have shown a difference. Also clinically, I think it might have been more important for the patient because, I mean, this is, I think, the more critical time for the patient, the 3 to 6, maybe a little longer time, where we want to expand the patency, but after 12 months, I mean, mainly, as I said, most of the lesions are healed already, and it's not so important anymore. So this is one difference. I mean, on the other hand, I mean, we have used the balloon a lot. Dr. Liestro from Italy has used it a lot. We might have used it in another way, so that might be a difference which will be hard to find out. We, for example, we predilate, and then we prepare everything for the drug-eluting balloon to come in a very fast and quick way. Take it in, inflate it very quickly. We all know that most of the drug you lose once you take it down and inflate the balloon. If you do this slow, you might lose it to the periphery. That might be a difference. There were not a lot of TLRs in the Medtronic trial, but if you take a non-coated balloon, for example, for restenosis to treat, there is, of course, you change the results. You should take a drug-eluting balloon in that drug-eluting balloon arm for treatment of restenosis, which I think was not done. These are some differences. And maybe also, I mean, the randomization was 2 to 1. And we all know in critical limb ischemia, you can have bad luck. So in a group of 70 patients, if you treat them the same way, you can have bad luck in one group. So with this randomization method, you have twice the chance to have bad luck. And that might have occurred maybe by chance in the drug-eluting balloon arm.
Do you think that there were any balloon-specific issues with the Medtronic product compared, for instance, with Lutonix balloon that would have resulted in the bad outcomes that we saw? Or not bad outcomes, the outcomes that we saw?
Yeah, so I don't know exactly. So, I mean, we have seen that the Medtronic balloon works in the SFA. We, and also Liestro, has seen that it also works below the knee. These results, also single results, are quite impressive. And maybe in terms of amputation, I mean, if you lose some paclitaxel maybe into an affected foot, that might maybe influence the infection. So maybe if you have too much drug on, or you lose too much drug with one balloon, you might have, in this term, clinically worse outcomes with one balloon compared to the other, where maybe the drug is more fixed to the balloon and easier to get into the arterial wall. Maybe this is a difference to a BART balloon. We don't know exactly. However, I mean, the amputation rate in the Medtronic trial was, after 3 months, there was a trend for more amputation for the DEB, but it became significant only after a year. But I mean, between 6 and 12 months, it can't have anything to do with the drug, so it's also hard to understand.
Thank you.
Okay, we have to move now.